Right, so people can gain from it, those who missed the session and those rest. So request our next speaker, because she has to go to the other session, and we're going to now introduce something very different. We're getting an American ophthalmologist, Dr. Cathleen McCabe, who's come all the way from Sarasota and runs a very high volume ophthalmic practice. And America, as you know, is the mother of all healthcare systems, and they have not been able to manage the Obamacare. But they brought that idea to Prime Minister Modi. He wants to do it from October this year. Let's see how it takes off. So, Dr. Cathleen McCabe, it's to you.
Thank you, and thank you for your invitation to speak today. And I'm just going to tell you a little bit about my experience, which is this is not the right talk. Sorry, it's the ASC talk.
So one of the things that while she's getting a talk ready is that Mr. Ganandar was saying that the ramp is now necessary in Tamil Nadu. But I don't think this facility would require a ramp. Would it by law?
Yeah. See, any hospital, once you have to operate a hospital, if you want a hospital license, today it's mandatory in Tamil Nadu.
99% of the eye practices now will never be able to get accredited. It's a new hospital, not the...
There we go. So my experience in the United States is in creating an ASC ourselves. Ophthalmic surgery was performed in hospitals, but in the recent past, about 70% of ophthalmic surgeries have been done in an ASC. There is a shift more recently to more multi-specialty ASCs, and a lot of these are actually being at least partially bought up by corporations. So what's the advantage of being in an ASC versus a hospital? Cost. There is, and we're going to talk a little bit more about this in a minute, but there is an estimation of a savings of almost $1 billion in 2011 by having surgeries done in the ASC outpatient setting rather than in a hospital. There is greater flexibility and efficiencies in scheduling, lower turnover time, increased surgical volumes. You can have a dedicated ophthalmology-only staff, which really helps with education and efficiency. And you have surgeons in the one entity who are invested in bringing on expensive and new technology. Lower infection rates have been shown. But it's still a very variable situation with geographic locations. Some of our states have what's called a certificate of need, where you have to show that there's a need for a new ASC before one is built. And in those states, as you can imagine, there are fewer cases that are done in ASCs. There are fewer ASCs in general. So in contrast, you can see in Colorado about almost all of the cataract surgeries are done in ASC versus in Green Bay, Wisconsin, which has a certificate of need, and only about 2% are in an ASC. And it's estimated that the cost of constructing an ASC today is about $2 million per room, fully equipped. Very expensive. So here's the difference, and in our environment, there's actually a difference in facility fees that are paid for a hospital versus an ASC. And this is where that cost savings came from, that 2011 study. So even for the patient, there is a savings in being in an ASC, because patients in our environment where they're covered typically have a 20% copay, and that 20% copay is significantly less if it's done in an ASC that has a lower facility fee. So what are the staffing advantages? Well, it's a controlled training environment, and in fact that's another thing that our organization AAOS is involved in, is trying to make sure there's very consistent measures and certifications for training of ophthalmic staff so that everybody kind of knows what they're doing. The staff can be familiar with individual surgeons and their preferences, and they may have just a single specialty focus, so they're not really, you know, moving from a GI to an ophthalmology to another case that might be pain management or something like that. And as has been already mentioned, technology is rapidly evolving. There's a lot to know, and if the staff is also focused on just new technology in ophthalmology, that's a big advantage. So we have lots of regulations. I know you have some as well. We have more and more every day. In 2015, we adopted ICD-10 coding, which we had not had, and as you know, that's a lot of codes, and in the United States, that's used for reimbursement purposes. We have all of these different alphabet soup of regulations. That last one is something that's coming, and that's patient satisfaction surveys. So with that in mind, when you are creating an ASC in the United States, and here, all of the things that were talked about, good lighting, comfortable seating, thinking about whether or not there's air conditioning, cooling, metal chairs, things like that, become more and more important when your reimbursement is going to be tied to satisfaction surveys of the patients who use your facility. There are lots of resources in the United States to help with that. AUS, like I mentioned, ASCA is for all surgery centers, not just ophthalmic surgery centers. And one of the things that these organizations really help us with is benchmarking. So to be successful and to know where you fall compared to your competitors, benchmarking is a key measure. And there's business benchmarking, clinical benchmarking. All of these things produce all of this information, which I don't expect anybody to be able to read, but it tells you things like cost per case, surgical days per year, number of cases per surgical day, per operating room, per surgery type, and what your employee FTEs or clinical hours are. All of these measures that help you get an idea to ask more complex questions. So you can ask questions like, do ASCs with femtosecond lasers conduct more cataract surgeries per OR than those without? It's hard to know if you don't have an accumulation of all this data. Well, we can find that out by looking at the data in respondents with our AUS surveys. And what we found is, as you can see here, the cataract surgeries per OR per day were slightly lower if you had a femtosecond laser, but total incisional cases per OR per day were not significantly different. However, if you ask the question a little bit differently, do ASCs with femtosecond lasers conduct more cataract surgeries in general, in total, than those without? And the answer is unequivocally yes, they do. So there are efficiencies and marketing advantages that may be present. All this data does is tell you facts. It doesn't tell you cause and effect, so there is another step that has to be put together in order to know what the data means. But another question you might ask, ASCs with femtosecond lasers, are they more profitable than those without? It's hard to know without having some facts and data, but we can look at that and see that actually the net income ratio is higher in facilities with femtosecond lasers, even though there's costs and maintenance fees and costs for the patient, and maybe even decreased efficiencies. So we can look at metropolitan areas versus rural areas and ask questions about that. And the purpose of this is mainly to tell you that there are lots of data that you want to both measure and interpret as you bring on your own ophthalmic ASC or hospital, that you need to know how you're doing compared to your competitors and in general. And so you might ask, are there more clinical incidents per thousand in high volume centers? It's an argument that's sometimes made, saying that high volume centers are not as maybe as focused on what's going on. Oops, sorry. I did want to show you that. So let's look back. I think we can get there. There we go. So total ophthalmic patient cases, you can see if you look at the ophthalmic patient cases that are the median or above, that is slightly lower than the average incidence per thousand. But if you look at the top 75%, the ones that are doing the highest volume, it's significantly lower in adverse events. So do you want to make a single specialty, an ophthalmology only ASC, or is a multi-specialty ASC going to be better? And if you look at this, there's really very little difference actually between the two as far as cases per OR day, but definitely more efficient on the financial side of it when you look at net income ratios. So there's a question again about group versus solo practice, and we have these same dilemmas. Ability to incorporate multiple ophthalmic specialties can be advantage, though, for better integration of patient care. And I was interested in hearing how, you know, there'll be a patient maybe that sees all different specialties, but that's not coordinated. And I think one of the things that we think is a blessing and a curse in the United States is our mandatory need for EMR. And in that instance, we do get to share all the information with other providers in a very efficient way that makes it a little bit easier maybe to integrate some of that care. And then, of course, there's sharing of risk and costs among your peers. So what's happening right now in the United States? There is a consolidation of the market. There's a lot of interest in private equity and venture capital investment, in clinically integrated networks, in other ways of making larger organizations out of individual practices. There's going to be a greater regulatory burden in the future with performance measures like satisfaction surveys and cost containment measures that will be directly related to reimbursement. We have an aging population, but static or declining numbers of providers. Physician and staff burnout is on an increasing trajectory right now and a growing concern. There is this continually evolving technology and the financial obligations related to that, and concomitant to that are increasing patient expectations. So what might we see in the future? Larger, more integrated networks of ASCs and clinical practices. We're going to see maybe that quality of care and efficiency will improve as best-of-class guidelines are created to manage these larger organizations. It might be more difficult to be a single-owner practice or ASC. There'll be greater vertical integration in these large groups to meet the growing need for eye care services, and we're going to see continued innovation and growth with emphasis on providing all aspects of eye care in one organization. Thank you for your attention.